Come forward, please, if you're here.
You're good.
Joe, you did the invocation for us here. I call this meeting to order at 20 after 1, and Councilor Byrd will do the invocation for us, please.
Go to our Lord, be the dog list. The most gracious Heavenly Father, we come to you today with open heart and just thank you for the blessings you have bestowed upon our tribe. We thank you for our veterans who've made it possible for us to take care of our business today. We just thank you for our people, and today we just give thanksgiving to everything you have done for us, and just guide us and lead us as we make decisions on today, our tribe today, people. In Jesus Christ we pray. Amen.
Gail, will you call the roll for us, please?
Janelle Fulbright,
Present.
Dick Lay,
Here.
Jack Baker.
Here.
Hardy Buzzer.
Here.
Joe Byrd,
Honey?
Julia Coates.
Here.
Jody Fishing Hawk. Don Burden. Connie Glory Jordan.
Present.
Frankie Hargis.
Present.
Lee Keener.
Honey?
Curtis Snell.
Here.
Denise Taylor. Here. David Thornton.
Honey?
Victoria Vasquez. David Watkins. Carol Cowan Martin.
Thank you. Chair will entertain a motion for approval of the minutes.
I make a motion to be approved.
We have a motion and a second. All in favor, let it be known by saying aye.
Aye.
Any opposed? The minutes are approved. Next, we'll go right into reports, and first is Claire Moore. We've got someone substituting for Mr. Valyers today. Welcome.
Good afternoon. Mr. Valier obviously couldn't make it, so sent me again. So I think he sent out his report. I wanted to highlight a few things. We continue to actively recruit physicians, as well as a clinical director. We think we're getting closer on filling that position. Also want to highlight that our MRIs is back up, and finally we think we're running smoothly, and it should be good to go for the long term now. So we had some bumps in the road, and we think we're past those, and that's up and running, which is a good thing. Also want to point out our revenues are up this year compared to last year, which is always a good thing for us. That allows us to provide more services and do more things. With that, I'd open it up for any questions.
Councilor Hargis?
I'm sorry, I can't remember your name, and we need it for the record.
Kelly Batiste.
Madam Chair.
Yes. Go ahead, Councilor Watts.
Thank you, Madam Chair. I think that the CHS or contract health service numbers need better explanations, and I don't know that it's in the report on what's Cherokee Nation versus what's us, and the delay in deferred and those kind of things.
Okay. So you just want it broken out between?
Yeah, I'm having a hard time determining what patients at Claremore, are they actually getting covered, whether it's by Cherokee Nation or by a
Okay.
Indian hospital.
Okay.
And then next month, could George have a more detailed staffing report, like how bad we are in terms of staffing, or how bad it is, I mean?
Or how good we are?
That's true. Except I believe we're short a severe number. Not saying the people there aren't good, I'm saying that the staff shortage, I think, is extreme.
Sure.
Thank you.
You bet.
Anyone else have any questions? All right, thank you for that good report.
Thank you.
Next is Cherokee Nation Health Services, and I think Ms. Davis is unable to be here today, so
Brian Hill?
Brian Hale's filling in for her. Welcome, Brian.
Thank you.
I believe you've all got the report in front of you for September 2014. I want to highlight we're 14% above our revenue from the same time period last year. Number of visits are up about 5% across the board as well. And then as far as some other highlights, the Northeastern State University Physician Assistant Program has been approved by the state regents. They'll be starting their first class, I believe, in 2016. We're going to be part of that along with Creek Nation, NEO Health, as well as Northeastern Health System. So we're excited to be part of that program, able to train more providers in our community. Then also we achieved accreditation from the Accreditation Commission for Healthcare. This allows us to provide and bill for durable medical equipment as well as especially diabetic supplies. So, I'd be happy to answer any other questions you all might have about the report.
Yes. Councilor Burton?
Our optometry clinic,
Yes, sir.
are there any changes taking place there in the future as far as expanding out to other parts of 14 counties?
Yes, I believe we are going to have additional optometry services at some of the other clinics as we've renegotiated the NSU contract.
Okay.
We're also allowing for what's called some floater optometrist positions so that if one calls in sick or has leave, have 2 floater positions that can go and fill in.
Okay, thank you.
And we're also aligning their schedules more to be in line with Cherokee Nation holiday schedule as well.
Okay, thank you, Madam Chair.
Councilor Thornton?
Say, do we have any doctors online that may come into Redbird Clinic?
I believe they have one tentatively recruited, and I'll defer to Dr. Montgomery. I believe they have Dr. Brian Rogers lined out to come into Redbird. And we're still looking for 2 more and still looking to recruit 2 additional physicians.
Okay. Thank you.
Yes, sir.
Yes. Councilor Argus?
I've had several complaints about Dr. Turner, not him specifically, but that he's not in the Mankiller Clinic. He's working at Hastings. Are we going to replace him, or can we have him in the clinic more often? Because I have someone who was supposed to have an appointment, say August 6th, and they moved it to January 12th, so.
The only time Dr. Turner works at Hastings is on the weekends when he fills in the emergency department.
Well, he's missing dates at Mankiller from what I'm told. I've had several complaints that he's not in the clinic.
I'll have to find out why he's not, because he only works Hastings on the weekends.
Okay, would you check into that?
Yes, ma'am.
Because if he's not going to be in there, we need another doctor down there immediately.
Councilor Thornton?
Yes. I have a lady that has needed a wheelchair here for a few months, and she's went in and filled out her paperwork and everything, and now they want her to come back in, fill out paperwork again, and they need to take care of this lady. So,
Do you know
Brett
where
knows
she's
about it
where's she going?
at Redbird Clinic.
Okay. Maybe after the meeting, you can give me her name and we can make sure she
Brett
gets.
has all the information.
Okay.
Okay, so we need to look into that as soon as we can, get that situation taken care of.
Councilor Watts?
Thank you, Madam Chair. So, I can't remember, what is the name of that? It's a Medicare program, I think, that does that equipment right. Is it MERT?
Well, it's not a Medicare program. It's a Cherokee Nation program, but the medical assistance program, yes.
Okay, I had thought that was a Medicare-sourced monies, but it's called MERT, is that correct?
Correct.
Okay, so who typically in the process would administer that? Is it contract health? I mean, I end up going to Brett and inundating him with additional requests, but who should it be in the facility? Is it the contract health office?
The way we have it set up at Hastings is that we have a patient advocate and then a MERT coordinator that handles those requests and the disbursements.
What about at Claremore?
I don't know. I'd have to defer to Mr. Batiste.
Okay, Brendan's there. I didn't see you. Okay, so there is something going on, not just at Claremore, which would be the one individual staff person, but other staff. There's something going on that people are not getting the MERT information. Somehow they're getting out of the hospital are released and they're not getting these kinds of critical pieces of equipment that are needed. So I would ask that you review that and make sure that there's, during the process that our patients go through, because they're already hurting or
Claremore?
not just Claremore, because I'm getting feedback from those that may show up at Hastings or elsewhere too. And then there's the issue of what I think Brett and I see maybe more often is they don't go through Claremore, but they're a patient of Claremore, but it's an emergency situation maybe where they've been put into a facility in Tulsa. And somewhere along the line, they get home and they're in need of a wheelchair and they have no wheelchair. And we're finding out 2 and 3 weeks later or something like that, that we can't do that. So if we could review that process, I'd really appreciate it. And since you're not Connie, there's this number of questions I guess I'll have to email, but we keep pushing stuff down the road, so maybe. One thing I will say is thank you for the flu shots at our community meetings. They were appreciated. I think the numbers were low because they were a month later than what they were supposed to be. So, but we still appreciate it, and the staff was outstanding. Thank you. Thank you, Madam Chair.
Counselor Buzzard?
Yes, Brian, you're probably aware that we're losing a pediatrician at the J Clinic. Are we recruiting another person to take over that position?
I believe so.
Okay.
I believe they're already working on it.
Certainly needed. Another question, and I'm not sure, in the insurance collection, I've had a couple of people call me that, and they were elderly people, they had insurance, had a Blue Cross Blue Shield insurance, and also had Medicare, Medicaid insurance, and they said they're not getting any EOB from Medicare or Medicaid. It sounded to me like they're only billing Blue Cross. Are we not trying to pick up that other part of the insurance?
They should be billing all of those. If they're not getting any EOB, we need to look into it.
Well, I'll get you a couple of names.
Okay.
You check into it, because I've had this same lady call me 2 or 3 different times. She said, I never get an EOB from Medicare or Medicaid insurance. And I'm wondering if we're not billing for it. So anyway, we're just missing out on some dollars if we're not. So I just want to bring that to your attention.
Thank you.
Thank you. Thank you, ma'am.
Anyone else have any questions? All right, thank you.
Madam Chair, may I distribute some materials for the council members, please?
Yes,
This
please.
wasn't on the agenda, but I'd like to do this.
We're always happy to hear from you, Dr. Montgomery.
November is Diabetes Awareness Month. Because of this, there was a general staff meeting of all the medical providers last week here in Tahlequah. I don't know if you've heard about it, but all the providers throughout the system came to Tahlequah, and we had a day of educational activities for our providers to hopefully enhance their ability to treat patients with diabetes. What I've distributed to you is the hard copy of a PowerPoint presentation that is a brief overview of Cherokee Nation Health Services, but is also an overview of the diabetes services that are provided to Cherokee citizens through Cherokee Nation Health Services. So I thought it appropriate to give you this information because I think it's been requested in the past. And I think a periodic attempt to try to give you the information to tell your citizens that you represent what's going on in Cherokee Nation, specifically with regards to the treatment of diabetes, would be helpful. And again, with your permission, Madam Chair, I'll proceed with this.
Yes, go right ahead.
Most of this, the initial pages, they're numbered down the lower right corner. You know, or well aware on page 3 is a brief description of the health services that are available through the 14-county tribal jurisdictional area. The thing I'd emphasize, the third bullet, Cherokee Nation Health Services accounts for 8.25% of the total IHS service unit population and provides health care to 38% of all eligible American Indian and Alaska Native populations served in Oklahoma. Again, this is to emphasize that the impact Cherokee Nation has on the total IHS user population. Then you'll see listed the number of visits. These numbers are frequently cited, and you can see the steady increase, and this is reflected in the report today. The total number of patient visits steadily increased through Cherokee Nation Health Services. In fiscal year 2013, those visits exceeded 1 million visits, and we expect that to be the same or even higher for fiscal year 2014. The next page, page 5, just outlines the tribal jurisdictional area, the location of the clinics and the various hospitals. I'm sorry, that would have been page. And then on page 5, a brief description of the scope of services. Again, most of this you're aware of, but I'd also point out that the services, inpatient services, include obstetrics, gynecologic surgery, orthopedic surgery, podiatric surgery, and emergency room services. The core services at all the clinics include primary care, pharmacy services, radiology services, laboratory services, and nursing services. Some of these other services vary from clinic to clinic, as you well know. Page 6, again, just outlines for you the increase in patient visits that have occurred through Cherokee Nation over the last 8 years. You can see the significant increase that occurred in 2009 when Cherokee Nation assumed responsibility for Hastings and all of the outpatient services provided there. Page 7, every month when you get the health committee, you get a breakdown of the diagnosis, and consistently the number one diagnosis that's logged in for patients' visits is diabetes. This is to emphasize the importance and the impact of diabetes on health services and the patients that receive care through Cherokee Nation. Page 8, this is to try to give you some idea of the impact of diabetes on a financial impact. And this is from a study that was done several years ago. It's funded by HRSA, called the IHS Improving Healthcare Delivery Data Project. The average annual IHS total treatment cost for adults with diabetes was $6,000. When you added cardiovascular disease to that diagnosis, it doubled the cost. So again, this is to emphasize the impact of that. And then the final bullet there is 15% of adults, this is an estimate from that study, 15% of adults that have diabetes account for 1/3 of the total costs attributed to healthcare. Again, emphasizing the impact of diabetes. So now let's look at what we do in Cherokee Nation. On page 11, you'll see a couple of different studies that cite the prevalence. When you're talking to your citizens, they often will ask you, well, how many people among Cherokee Nation have diabetes? And different numbers are used. The American Diabetes Association uses a number of 15.9%. From the study, the first study cited there, the National Health Statistics Report, 17.5% of Native people report that they've been told they have diabetes. So again, that number among Indian people is between 16 and 17%, which compares to roughly 7.6% among whites. Easily double the number of Native Americans have been told they have diabetes compared to whites. Again, I want to emphasize that impact. When I was in private practice several years ago, in an outpatient clinic, if someone walked into my office and I had to tell them that they had diabetes, my resources were limited. If I was lucky, I'd spend 10 or 15 minutes explaining this news to someone that didn't want to hear this news that would impact the rest of their life. I would try to emphasize to them what I thought they needed to do with their lifestyle, and what I would need to do with them medically, and then I would hand them off to my nurse, who also was very busy and might have 10 or 15 minutes to instruct them on the use of an oral medication. They might have 15 minutes to show them how to use a syringe and how to draw up insulin and administer insulin. In the clinic where I worked, we did have a nutrition person, but they weren't covered by insurance, and if my patients wanted to access them, they had to pay for it but with cash. So again, the resources a few years ago in private practice when I was practicing a physician, and I thought I did a good job, but those resources were extremely limited, extremely limited. So now let's look at what Cherokee Nation does and contrast them. We have primary care teams that are comprised of a triage nurse, there's usually a case manager, and all of the clinics have a variety of different people that are providing educational services for our citizens. And it's a multidisciplinary approach. When a patient is diagnosed with diabetes, we have strategies in place to make sure that they see a dentist, that they're referred to the optometrist, and that they're counseled by their pharmacist on the use of their medication. These services were not readily available in the years that I was in practice, in private practice. And I want to specifically indicate that there are 5 certified diabetic educators distributed through our clinics. These people they have to meet certain criteria to be qualified for that. They have to have 2 years of training, and then they have to pass a rigorous exam. And again, they're what are called CDEs, Certified Diabetic Educators. We have 16 registered dietitians scattered throughout the clinic system. And we have 8 pharmacists that provide intensive diabetes management, and one of those pharmacists is a certified diabetic educator. Again, the ratio of these different people vary from clinic to clinic, but I want to emphasize that they're widely distributed throughout all the clinics to provide intensive education and assistance when people are diagnosed with diabetes. Also, in 6 facilities, there's what is called the Cherokee Nation Diabetes Self-Management Education Program, which is accredited by the American Association of Diabetic Educators. This includes 4 educational sessions that are conducted by 2 primary care instructors that will include either an RN, a dietitian, or a pharmacist. Again, these are classes, these are educational services provided to patients when diagnosed with diabetes. Now, how is this funded? Again, most of you, I think, have heard of this, but I'll try to make this, it's a little confusing, but we receive a significant amount of funding each year and have for several years, in excess of $6 million through 2 different programs. The first is called the Special Diabetes Programs for Indians Community Directed Grant Program. The second is called the Special Diabetes Program for Indians with Diabetes Prevention Grant Program. One is a community program, the other is a prevention program. We also have in place a strategy for management of patients that comes through the Institute for Healthcare Improvement called IPC. And again, this is a treatment strategy utilizing the different providers to address the treatment of diabetes. These, and bear with me, I get this very clear. The SDPI, Community Directed Grant Program, provides funding for a variety of services, including syringes, testing supplies, therapeutic footwear. This money also supplements pharmacy budgets for medications. It also supplements the monies needed to pay salaries for the clinical staff, which include the RNs, the registered dietitians, and the certified diabetic educators that I mentioned previously. The Special Diabetes Prevention Program is, again, a separate program that provides a 16-week class that provides lifestyle coaching, follow-up, and quarterly after-care activities for people with pre-diabetes. So again, I want you to know there's an emphasis not only on assistance with management and treatment of patients diagnosed with diabetes, but also a very intensive program for prevention of diabetes. On page 15, we get into some of the unique things about Cherokee Nation. This is a tough graph to look at, but what it's trying to emphasize is the shift in medical therapy that's occurred over the years. On the left-hand side of that graph, you see the percentage of patients treated with insulin, and on the right-hand side of the graph, if you look in the right-hand corner, you'll see the introduction of a new medication or new class of medications. It's got a fancy name. They're called DPPV4 medications. This is one of the newer medications that accounts for 20% of our total pharmacy budget, but I wanted to just point that out that we're offering patients the newest treatments for diabetes. Now, how do our providers do? Let's look at page 17, if you would, with me. You'll see 2 graphs.
I don't think we've got it.
Every year for...
I don't think we have that.
You don't have 17?
Each graph is a separate page.
Yeah, we're talking
So
about
it's
slides,
actually on page
basically.
8 for us.
Page
Is it
number,
page 8?
slide number.
Okay.
Slides per
We've got,
page.
yeah, we've got
Okay.
2 slides per page. and
All
you
right,
have
I want
one.
you to shift to this one then, okay? And I'm sorry if it didn't come out right.
But which page are you on?
I'm sorry for the confusion. Give me page 9? Okay. Everyone with me? Every year there is what's called a diabetes audit. This is where data is extracted from our electronic health record and submitted to IHS. Then they feed it back to us with comparison to other IHS facilities throughout the country. Engaging how providers do in the treatment of diabetes, one of the most important measures is what's called hemoglobin A1C. Have most of you heard of that? It's an average measure of the patient's serum glucose over the preceding 6 to 8 months. The lower hemoglobin A1C, better control. the higher hemoglobin A1C, the less well they're controlled. What you'll see from 2006 to 2014 is that the percentage of patients with a controlled hemoglobin A1C has dropped by about 10%. Is that good? Is that bad? We'd like to see that number stay the same, probably go up. But I thought it really important to show, though, that second graph that's alongside it, I hope, which shows the total number of patients with a controlled hemoglobin A1C. And that number has doubled. That number has doubled from 3,000 to over 6,000. Let's go to the next graph. And again, I hope it's on the next page. It's going to be at the percentage of patients with good control of their blood pressure. A good control of blood pressure in someone with diabetes is a blood pressure less than 140/90. And although it fluctuates quite a bit, the trend line very clearly shows an improvement over the years that the audit's been done. And the total number of patients, again, has doubled. The total number of patients with good control of their blood pressure has doubled. Are you with me? All right, great. Is cholesterol important? It's especially important in people with diabetes. So this next graph looks at the number of patients with their LDL cholesterol less than 100. And again, the trend line shows a significant improvement over the years that this audit has been conducted, and the number of patients with the LDL cholesterol less than 100 has significantly improved. With diabetes, one of the things they fear most is problems with their feet. They develop what's called diabetic peripheral neuropathy. They can develop what looks like a simple sore that can become a very serious sore, an ulcer that can lead to very serious complications. So we emphasize the need to perform a complete foot exam. And you'll see that the number of people getting a foot exam has stayed about the same, at right around 75%. The number for the IHS is around 59%, so we far exceed that expectation among IHS. Then let's go to the retinal exam. One of the other important complications of diabetes is what's called diabetic retinopathy. And you can see the trend line there. The number of patients getting a retinal exam has increased steadily over the years and is at about 75% at this point. The final set of graphs is the number of patients receiving dietary instruction from a registered dietitian. You'll see a trend downward in this. This is just a manpower issue. We need more people to do this. A dietitian can only see so many people in a day, and our dietitian staff has not significantly increased over the years. But that number of 50% still exceeds the expectation or the average for the IHS in total. I've spoken quickly. I've gone over this quickly. I hope, though, that I've given you a flavor of what's going on out there and the work that's being done, and also the success and good job that our providers are giving to those patients that access our system with diabetes. I wanted to conclude by recognizing someone also. I don't think she gets a lot of recognition. She's been with Cherokee Nation several years, and she's the director of our diabetes program, and that's Teresa Shadow, and I'd like her to stand. I'll entertain any questions.
Make a comment. I see one lady at the gym that takes, I think it's the prevention, is it like one night a week or?
Should be, yes.
And the incentives that, I mean, she's lost 8 pounds and cholesterol is down and all the glucose, and she's just so happy that she took the class, and said some of the incentives, that would be a reason to join the classes. They provide them with like a pair of shoes, workout shoes, and then discounts to our local restaurants here. And she's just all excited about the class, and I didn't know it even existed. But you guys are doing a good job, Dr. Montgomery.
Thank you. Thank you very much. Any other questions?
Councilor Keener.
Thank you. Dr. Montgomery, have you noticed a trend on people under 18 getting diabetes?
It's going up. That was one of the speakers at our conference last week, just emphasized that the number of, and it's the number of teenagers with type 2 diabetes, which you wouldn't mean is not typically the case, though. It is increasing, yes. And it's tied to diet, lack of exercise, and weight gain.
Thank you.
Mm-hmm.
Thank you.
Victoria.
Yes, I have a comment. Recently, I underwent the pre-diabetic check through the doctor at the Bonita Clinic and spent several visits with the dietitian there. And within 6 weeks of me watching what I ate and following the guideline, which was very good, I was able to lower all my numbers, and now I'm no longer pre-diabetic. And it was very important to me because my mother had diabetes, and all of her family died from complications of diabetes. So I was most impressed with the level of her knowledge and the things that were so easily done in my home, you know, with the recipes and just small changes. And it was amazing that you can truly make a difference in 5 to 6 weeks if you follow that guideline. I was really, really happy with her.
That's great.
Thank you.
Thank you for that feedback, too. Thank you very much.
Counselor Watts?
Thank you, Madam Chair. Is there a chance this could be put on the website?
See, why not?
Thank you.
We might make it a little more, just presentable on, but,
I think you could easily convert it to PDF to YouTube, so it just is a rolling slide.
sounds good.
Thank you.
Indeed. Anything else?
And will you be emailing a copy to all of us too?
If you'd like, I
Okay,
can.
thank you.
I have a comment. I think that any of our people who have diabetes are well taken care of, but probably more so than the average person that is non-Indian that goes to the doctor, because I know down at Redbird in our newly remodeled facility, there's a wonderful kitchen down there. They teach them how to cook and how to eat correctly, and it's just a wide spectrum of things like taking care of their feet, and they have shoes that they come in for fittings, and I just think we take wonderful care of our diabetics, but of course there's always more to be done, but education, I think, is the key, and weight loss and more physical fitness, and we're attaining a lot of those goals, and we really appreciate this wonderful report that you gave us in depth.
Thank you.
We need to let people know what a good job we're doing. Thank you, Dr. Montgomery.
And thank you for the opportunity, and again, I'm very proud of our providers. They do a great job.
Before you step down,
Yes.
for the record, we didn't get the lady's name that is in charge of the diabetes program.
Teresa Shadowan,
How do you spell the last name?
Chaudin. And
Oh,
Teresa is
okay.
without an H, Teresa.
Okay, we're familiar with that name. Thank you.
Okay, thank you.
Okay, we have in old business, none pending, new business, none pending. We move right on down to announcements. And we need a motion to adjourn. Okay, all in favor of adjournment? All right, we're adjourned.